Hi, everybody. We are going to go ahead and move into our next chapter talking about sexual disorders, which of course is always really interesting to most people. And you all know I like to use pictures and videos and things like that in my PowerPoints. It's a little bit tricky with this chapter. If I type in, the term sexual or sexual disorders or whatnot, I get things that are not appropriate for most audiences. So there will be a minimum of pictures in this. There will be a couple of video clips to link to, so I will mention that. And I also do want to give a warning that when we move to the paraphilias section later in this chapter, and I will give another warning, I am going to talk about pedophilia very briefly. So for those of you who don't wish to listen to that, there will be an unrecorded version of this on Blackboard. So that's an option for you. Okay, so to start with, to talk about sexual disorders, the big issue here is what is normal sexual behavior. The study of sexual behavior should be pretty straightforward, but it's not because there's such a wide variety of what is normal. So if we get away from the conception of psychological disorders as abnormality and think about it more in terms of the dysfunction that it causes, we're probably better off. So a wide variety of sexual behaviors occur in people, but if they don't cause distress to themselves or anyone, should we really label it a sexual disorder? And the answer is probably no. So the bottom line, we're not really sure what normal is considered to be except for that dysfunction piece. The study of this has been around since the 1950s, and a physician named Alfred Kinsey was one of the first to study it. There are numerous movies out about him and his work, like feature films, and I'd encourage you sometime to watch one of those. He was a really interesting character. And even though he's kind of blasted for some things that he studied, he really was a pioneer in opening up this subject for study, because prior to this, nobody talked about sexual behaviors. Of course, nobody studied it, and he was one of the first. He put out reports on males and females in the 1950s and the 1960s. He did both survey research, and he also, it's just hard to conceive of this, but he would bring people into his lab setting and have them engage in sexual behavior and essentially observe to see what kinds of things went on. So, this was before the time of human subjects boards and all that. So he published his reports separate for male and female. They were, of course, scandalous. They were really interesting. They certainly have to be criticized because, he could only study so many people. It wasn't a huge sample size. They were primarily Caucasian, middle-class individuals, so certainly not representative of everyone. But we have to give him credit because he opened the door. If any of you are more interested in this, Dr. Schroer offers a human sexuality class, which is excellent. So I would encourage you to take that if you have time. A little bit of interesting American history. In the early 1900s, Congress actually cut off funding. They voted not to fund research to survey American sexual practices because they were afraid that people would get offended or it would put ideas of deviance in their head. That's kind of hard to imagine, hard to believe right now. But it's important to remember that most of the time when you see a study on sexual behavior, it's survey research, of course. And think about the inherent problems in survey research. People often don't tell the truth, and especially if you're asking about something as private as sexual behavior, they are probably less inclined to be truthful if there's something that they're worried about or think that they do something outside of the norm. So surveys on sexual behavior are among the most biased out there, and when you read about a study on this, you really have to take it with a grain of salt. Okay, so we're going to talk about a couple of different disorders. There are lots in this chapter. There are sexual performance disorders, which we are not going to cover. We are going to start by talking about the one that I think most people may be somewhat familiar with, gender dysphoria, and then we will move into talking about a separate category of sexual disorders called paraphilia. So all this is just really interesting stuff. Okay, we'll start with the topic of gender dysphoria. The American Psychiatric Association made a big change between DSM-4 and the current DSM-5, and that is they took out a category called gender identity disorder, which absolutely needed to come out, and the only real gender disorder that's represented now is something called gender dysphoria. Dysphoria means unhappiness, depression. So before I go into a little bit more detail about that, I want to talk about some terms here that I think we all need to understand. And the first one is the term gender identity, because gender dysphoria deals with gender identity. Our gender identity is our sense of gender, of being male or female, neither, both. You know, now that we and all professionals consider gender to be along on a spectrum. I'll talk about that a little bit more in a moment. And so whatever gender you have, how you feel, who you believe you are, that would be considered your gender identity. And it's a spectrum. There are a lot of labels. A lot of people resist labels, of course, because gender is such a personal thing that sometimes it defies being labeled. But we're a society that likes categories and labels. And just to give you an example, Facebook in particular has over 70 different categories you can check for gender identity. So that's just the wide range that is available. Here's how we think about gender now, and this should be somewhat familiar to you. We now consider gender to be not binary, but diverse. It's a diverse spectrum. There are multiple categories, and people can belong to multiple categories, if you want to phrase it that way. Gender is fluid. It can change. It can change, over a lifespan. It can change on a more regular basis. And gender is not mutually exclusive, so people can have more than one gender. And we have evidence from neurobiology to support this. So there are some people who believe that, we're just kind of opening up all possibilities for people, but there is a biological basis for gender fluidity and gender diversity. So there's now really no doubt about that. So with those kinds of terms in mind, what is gender dysphoria? Okay, so I mentioned it's unhappiness. Gender dysphoria would be used to describe a person who is in distress. They are unhappy over the incongruence between their assigned gender and their experienced gender. There are lots of examples we could have, but a person is born biologically a female, but does not feel don't see that as their gender. And they are really unhappy about it. Now, the discrepancy between the two, just feeling as though you are different than what your assigned gender, that is not a dysfunction. That's not a pathology. But the distress and the unhappiness is for the DSM purposes. So the gender dysphoria has to include significant interference in your health. That should be healthy life functioning. So just like all the other qualifications of disorders that we've talked about, if it's interfering in your life, if it's causing distress to you, more so you than other people, but if distress to other people causes distress to you, then that would count. So that's the thing to think about. Gender dysphoria is not the same as gender nonconformity. Gender nonconformity is when a person feels that their gender identity is inconsistent with their birth sex assignment. And I actually just said that a couple of minutes ago. So gender nonconformity is not a disorder. It is not a pathology. It's not something that needs any kind of psychological treatment, except if it results in gender dysphoria. So we're going to talk a little bit more about that. Gender dysphoria is the issue, not the gender nonconformity. Now, the DSM separates gender dysphoria into childhood and adulthood. Let's talk a little bit about the differences between those. So gender dysphoria of childhood is diagnosed before puberty, because of course prior to puberty there are no secondary sex characteristics that have developed, and this is usually marked by a child's desire to be a different gender and unhappiness over their assigned gender. So there are a bunch of qualifications to be met. I just want to give you a couple of them that are used to diagnose this. First of all, a desire to not develop or be rid of any developing secondary sex characteristics. So that would be breasts or facial hair, something along those lines. Preference for activities or dress of a different gender other than what they've been assigned at birth. And then a dislike of their sexual anatomy. So kids will oftentimes actually talk about how they do not like that part of their bodies. So there's a number of characteristics, but those are just some examples of what we would use to diagnose this. It tends to be diagnosed more in boys than girls. And remember, to be diagnosed with gender dysphoria, I mean, this isn't just gender nonconformity. These are kids that really are experiencing a level of distress over their assigned sex. In general, it starts to emerge between ages 2 and 4 when it does occur in childhood, and for some it may end by adolescence. So they find that once the secondary sex characteristics do start to develop, it ends for some kids, but for many others it does not. What we do know is that the earlier the dysphoria sets in and the more intense it is predictive that it will continue into adolescence and adulthood. So the degree of distress and the younger the age seems predictive of persistence of the dysphoria into adolescence and adulthood. Of course, we can treat it before it gets to that point, but this is what we're looking at. We don't have great numbers of persistence into adulthood because these are only people that have sought medical assistance for this, so it's a wide range. For boys, anywhere from 2 to 30% of, now this is childhood gender dysphoria that persists into adulthood. This doesn't mean 2 to 30% of boys have gender dysphoria. And then of girls, it's a little bit high, well, it's a little bit higher of persistence into adulthood. Between 12 and 50% of girls diagnosed with gender dysphoria will persist into adulthood. We know that there is a developmental trajectory that this follows along, and it varies somewhat for males and females. So for males, there is typically early onset, which is the between 2 and 4 for very young children, as we talked about. And the late onset development occurs at puberty or later, and then this may, as we talked about, may or may not persist into adulthood. For late onset. And for some individuals, there are lots of situations of individuals who go through puberty, they may get married and have kids, all the while having ambivalence about gender, and then decide to come out and to make some changes when they're a little bit older. For females, this is more typically early onset. Most females are early onset. But what this means is that the onset of puberty is often very, very difficult for these individuals because the changes are so drastic, especially for females. I'll talk about this more in a moment, but what helps is having a supportive environment and medical interventions. And for all kids who experience gender dysphoria, there are some comorbidities, by definition, depression, also anxiety, some impulse control issues. It's just a kid's way of dealing with the uncomfortable feelings that they're having. So as far as treatment for gender dysphoria, what do we do? Generally, it involves something called gender affirming care. And there are two ways to deal with this. And this is for kids and adolescents. First of all, there are medications, gonadotropin releasing hormone medications. You don't have to write that down, gonadotropin releasing hormones. But essentially what that does is suppress certain actions in the brain to suppress secondary sex development, sex characteristics development. Those are usually administered around 9 or 10. So basically it halts the pubertal changes. So girls will not have breast development, menstrual periods, and boys, lack of semen production, hair growth. So that's the first step. And then later on, if kids want to continue with this, gender affirming hormone therapy is given. So typically in puberty and adolescence, kids are not given opposite sex hormones yet. Now, sometimes this can happen. It's totally up to what the kid, the parent, and the doctor agrees with. But gender affirming care is the critical thing here. Now, what about psychotherapy? We have to be careful with this one because psychotherapy can be used, but it has to be using a gender affirmative approach. The American Psychiatric Association and the American Psychological Association have basically outlawed reparative therapy, which is used to try and change a person's sexual orientation or their gender identity. Not only do these not work, those are things that can't be changed, but they can also cause some real harm to individuals. So psychotherapy does not attempt to influence a person's gender. It is an attempt to deal with the dysphoria, to help build resilience in the person and comfort with themselves and really reduce those feelings of depression and anxiety. So that's what the therapy, if people choose it, is used for. Another part of the gender affirmative approach is using the child's chosen name and pronouns. So all those communicate signals to the kid of acceptance, love, unconditional, positive regard. Okay, so for adults, what are some of the treatments? It's important to understand that not all adults wish for gender affirmation surgery. Some with gender dysphoria are content to do hormone therapy, live their life as a member of the gender that they are, and not everybody wishes for that surgery. It's also important to separate gender identity from sexual orientation. Just like with gender, there is a spectrum of sexual orientations. It's also not binary. So sexual orientation is a separate issue from gender identity. And people who are gender diverse can have just as many can be on the spectrum of sexual orientations as well. So it's important to remember the difference between the two. One video I have here, and I'll attach this, I'll put the link for this in the description here. There's lots of videos, lots of case studies about people who have gender dysphoria, and this is an interesting example of a woman who was a high school football player and kind of did the typical pro-masculine things and always felt female, always believed to be a female, and just a little bit about her story. And this is an Oprah clip I found, so you just kind of have to deal with all the Oprah nonsense, although it's really not bad. So just an interesting example if you're looking for one. The treatment for adults for gender dysphoria is hormonal therapy, and even for people without gender dysphoria, they can use hormonal therapy. And then if possible or if wanted, the gender affirmation surgery. The gender affirmation surgery, I do want to mention, does not typically change the person's internal organs, internal sex organs, only the external ones. But the success rate is high. Most people find that it really helps their gender dysphoria, so that will continue to be a possibility for people going forward. So most people are really satisfied with that surgery. Okay, so that's the end of the discussion here about gender dysphoria. I hope I've cleared up some maybe misconceptions that you've all had or things that you didn't understand. This is a topic and an issue that's changing daily. In fact, I was just thinking I had to change my lecture quite a bit from last year because there have been so many new developments and so much new information that we have learned about this community of individuals, and it's pretty exciting to see how much more we're knowing and how far we've come with this. So the next section we're going to talk about is paraphilia. It's a completely different type of gender issue, totally different. It has more to do, actually it's not a gender issue, this is a sexuality issue. And I do again want to give the disclaimer that I'm going to be talking about pedophilia at the end of this, so if you don't want to listen to this, I get it, and this will be available on the unrecorded PowerPoints. So this is a really interesting category of sexual disorders, paraphilias. You may not have even heard that term before, but paraphilias, for most people, their sexual interest is directed towards consenting adults, other consenting adults, but there are a group of people who get sexual satisfaction from inanimate objects or hurting someone or being hurt themselves. So there are lots of sexual behaviors that are considered unusual but harmless within that spectrum that I talked about at the beginning of the lecture. But then again, there are a category of behaviors that are not harmless, and those are the ones we generally consider to be paraphilias. So paraphilias include sexual behaviors in which unusual objects or rituals or situations are needed for sexual satisfaction. So it includes things like non-human objects, so shoes, for example. It includes activities that involve inflicting humiliation or suffering onto another person. And it includes sexual behaviors with non-consenting partners. So that could include people who are intoxicated, people who are disabled and unable to give consent, children, that type of category. So we know that overt behavior is not required to diagnose, so fantasies or distress over them may be sufficient. But remember, again, you have to have that distress component. If people behave in these ways and they're not causing stress, it doesn't cause distress for themselves or someone else, we probably would not diagnose them with a paraphilia. It's also interesting to note that these individuals don't consider themselves to have a mental disorder. They consider that they may have some sexual interests that are varied or unusual, but they don't necessarily consider that. And lots of times they only get treatment when they get into trouble, either with a partner walks in and sees something, or they ask a partner to do something unacceptable, or they're arrested. And we'll talk about some situations like that. So that's the typical scenario. It is mostly men that are diagnosed with paraphilias, and again, men are more likely to act out sexually, and they're also more likely to get caught and perhaps receive some punishment for it, and they're more often in legal trouble. When women are diagnosed with this, it's usually a form of sadomasochism, and this one's really come under fire as to whether this should be a disorder or not. You know, we had the whole 50 Shades thing a number of years ago. I don't know if any of you read those or saw those. But again, this can involve non-consenting people. It can involve pain and punishment. So it does, in many instances, belong under this category. Now, the DSM-5 lists 8 different paraphilias. We're going to talk about just a few of them. And then they have this category called paraphilia not otherwise specified. So these are people that have sexual disorders that don't fall into one of those 8 categories. And they include these kinds of things. I just think they're interesting. Phone scatologia. I just think that's a cool word. Phone scatologia. So these are people that obtain sexual arousal from making obscene phone calls. That has diminished in years because, of course, everyone has caller ID and knows where the calls come from. Of course, you can get burner phones, things like that. So I'm sure this phone scatologia is not totally extinguished, but was more common back in the day when people used house phones and there was no caller ID. But interesting, that's how they get their sexual arousal. There is necrophilia, which is where people obtain sexual arousal by either being in the presence of corpses or have sexual activity with corpses. And then coprophilia, this one's one of the hardest to understand. These are people who obtain sexual arousal in the presence of feces, either animal or human feces. So that one's a little bit harder to understand for sure. One quick case example here we can give is Jeffrey Dahmer. You all are too young to remember when this all happened. 94, 104, 14. Yeah, way too young. The next page, I've got a couple videos that you can watch, and they don't show anything graphic, but what they're talking about is pretty graphic, because what this guy did, he's probably the most notorious serial killer, I imagine, is that he lured men to his apartment, drugged them, would kill them, sometimes dismember them, and then sometimes have sex with their body parts or their corpses, and then he would eat parts of them. It just is so beyond anything you can get your mind around, just so beyond. Fascinating case example, and he was tried. We'll talk about him again in the last chapter. He tried to plead not guilty by reason of insanity, but that was not successful because he knew what he was doing was wrong. He tried to hide from police. He tried to keep his victims from going to the police, and that's generally one of the criteria. So he was found guilty. I don't think this was in Wisconsin, and I don't know why there was no death penalty, but it was, life in prison, no chance of parole. And unfortunately, he wasn't in prison very long before he was killed by another inmate. And I say that's unfortunate because I feel like we could have learned some things from studying him. And actually I think it's the second video, is a jailhouse interview, a prison interview with him, which is really interesting. So he was diagnosed with alcoholism and also necrophilia. And this top one, I think I saved that for the last chapter. We watched some footage of his trial, but he absolutely had a sexual disorder along with alcoholism. Just an interesting case. Okay, well, let's talk about some of these paraphilias. One of the most common is frauderism. So you have to be really careful. This isn't happening now because the kind of scenes like we see here are just not happening. But this is likely to happen in public places where you can't move. So a frauderist is a person who gains sexual arousal by rubbing up against or touching a non-consenting person. So this happens a lot at things like concerts or ball games or, public transportation like this. And then the person escapes. So they would do it in a big crowd where they can get away because, of course, if you're being touched like that, you're going to immediately react. Or they might do this just before hopping off at the next subway stop. Let's see. So it's usually crowded situations, and we know that the person who does this may imagine having an exclusive relationship with the victim. So in their mind, that's like their boyfriend or girlfriend, and they're getting away with something naughty in public, even though, of course, that's not the case, and it's a crime because the person does not consent. So crowds, no escape. Most people diagnosed with this are young males between the ages of 15 and 25. There isn't a lot of persecution for this because they oftentimes will get away, but these folks usually are pretty habitual. So they may do this every morning on the A train into Manhattan, or, at every Ohio State football game or something. So sometimes they are caught. And we'll talk about treatment here at the end. So that's got to watch out for the frauderists in big cities. Okay, how about exhibitionism? This is certainly one that we have all heard about. This is actually, you may not know this is the most common sexual offense that is reported in the United States and Canada. It is an offense, it's a crime, because some of you might be like, who cares? Why is that a crime? Well, it's a crime. It's not an indecency crime. It's a crime because of its intrusive quality. If you're the victim, you didn't ask to see that. And it's offensive for people, and it feels confrontational, even though, as we're going to see, most of these folks don't actually approach or try and hurt anybody. So of course this is exposure of the genitals to unsuspecting strangers. They are not typically interested in sexual contact with the victim. And by the way, I want to mention, when I say most common sexual offense, sexual assault and rape are certainly more common than this, but they are less reported than this. So that's an unfortunate thing. Okay, so these people aren't usually dangerous. They don't usually want sexual contact with the victim. And they are often very consistent, just like frauderists. So they may just expose themselves in churches, sometimes happens in churches, or buses, in the same vicinity, on the same bus route. They may run down the street and, expose themselves to people driving in cars the opposite way, that kind of thing. The picture here of this young man, this is public news, so I'm not invading anybody's privacy or anything. So this guy was deemed the naked photographer in Columbus. He was, if you can believe it, excuse me. He was an attorney. I think he was in his late 20s, and what he would do is hang out after dark around the laundry rooms of Columbus area apartment complexes. So when there was like a separate building with a laundry room or whatnot, he would hang around, he would wait for young women to come out with their loads of laundry, he would flash them, and then he would very quickly take a picture of their face. And so when they finally caught him and went to his apartment or his house, he had all these pictures of these shocked looks on the faces of women, which coincidentally, maybe not coincidentally, this is what they're looking for. This is what exhibitionists are looking for, the look of shock on a person. So anyway, they caught the guy because he had patterns. He would always wear like a mask or a hat or something, but he would hang out at all the apartment complexes, and they finally caught him. He was a young lawyer in Columbus. Here's a picture of him, boy next door kind of guy. Nobody could believe it. Of course, he was fired and his law license were taken away. He is still, I think he's still in Columbus last I checked. This is like 10 years ago. And he is not practicing law. He's not allowed to do that. But he's providing legal assistance to people. So I guess you're allowed to do that as long as you don't hold yourself out as a lawyer. But anyway, so interesting. The naked photographer. So these crimes tend to be most common in the spring and the summertime, because of course that's when it's warmest. Sometimes the exhibitionists will use gestures, but they rarely approach their victims. Now, do any of you know how you're supposed to react if you're confronted with an exhibitionist? And I'm sure a lot of you know this. You are not supposed to react at all. See this woman's face? This is what they're looking for. Shock, disgust, fear. That's really what they're looking for. That's where the sexual arousal comes from these people. So the best advice is to show no reaction. Now, you don't want to insult the person or say anything to them or try and provoke. The best response is just to no response and just walk away. Generally, they're not going to hurt you or anything like that, but don't respond. Now, the courts tend to be pretty tough on exhibitionists, and the reason is because there's some evidence that a small percentage of sex offenders, but 10%, may begin this way. So they try and nip this in the bud, so to speak, I suppose. Psychologically, with these people, and they're almost always men, they may have puritanical beliefs about sexuality. In psychological examinations, they found this. Many of them doubt their own masculinity and have feelings of inferiority. So this is positively reinforcing for these people. If you think about it, they flash, they get that look of, oh my goodness, and that's positively reinforcing for these folks. So, yeah, there you have it. One last point here I want to make is that, whoops, I'm a little bit ahead of myself. That is the last point I want to make about exhibitionists. Moving on, the next disorder I want to talk about is fetishism, a fetish. We've all heard of fetishes. These are people who obtain sexual arousal from non-living objects. Clothing items are very common, like high-heeled shoes or silky scarves. There are people called partialists who may obtain arousal by just a part of the body, like feet. You've heard of a foot fetish kind of situation. And for these people, sexual arousal cannot occur without the object. And so that becomes the dysfunctional part of the person's life. It may interfere with normal sexual relationships and bother potential partners. They usually do not interfere with the rights of other people, except when they may ask their partner to wear or to behave a certain way, for example. But we also know that because of this fetish, it may promote burglary, once in a while assault, but not usually. But these people are usually harmless. Now, I've read lots of case studies. I've never treated anybody with a paraphilia, but case studies about people, men going up and stroking women's hair. They had a hair fetish. In fact, in Columbus, not too long ago, there was a case of a man who was arrested for fetish, and he would always do it in Target. This is the consistency. He would go up to women and say, "You have a bug in your hair," and he would stroke their hair pretending to remove the bug. So he would just do that over and over, and eventually the guy got caught because, there's cameras everywhere. So he was eventually reported. They may steal underwear from laundromats. So sometimes these people lurk around in laundromats looking for items to steal. They may steal from stores. So sometimes the burglary can occur. People with this are fueled by the illicit nature. It's the excitement of doing something forbidden, something secret, something naughty that really fuels the fetish of these people. Now, this can also include using objects in a sexual way for self-gratification. For example, and this is going to make you cringe, but I'm going to tell you anyway, a good friend of mine is a charge nurse in an emergency department in Columbus, and she said, "You would not believe the number of people who come in with objects inserted in their genitalia to try and obtain sexual arousal. Pencils, other long objects they've extracted from males and females. Now again, this kind of thing was normalized in the 50 Shades of Grey kinds of movies, but if it causes harm to someone else, to yourself, then it would be considered a fetish that is harmful. So something to keep in mind. Okay, a couple more here. Voyeurism. Let's talk about this one. This one's getting less common also because so many people have video cameras in their house. But voyeurism is when a person observes unsuspecting other people either in states of undress or in under sexual activity. So we used to call these people peeping toms, and again, it's the excitement of doing something illicit, something secret, something you're not supposed to be doing. And some people say, well, why don't these people just go to strip clubs or something if that's what you want to do? Why don't they just rent movies that you can watch? Well, that's not the same, because for a voyeur, again, it's that excitement over doing something you're not supposed to be doing. So they do not get the same sexual satisfaction from those kinds of situations. Okay, two more. Transvestic disorder. Let's talk about this one. The DSM-5 changed the name of this from transvestic fetish to just transvestic disorder. And I'm going to talk in a minute about some of the controversy that is associated with this. So these are individuals who obtain sexual arousal from dressing in clothing of the opposite sex. Okay, now this isn't meant to be, so these are folks that not just use clothing for sexual arousal, they dress in clothing. So maybe a man wears women's underwear. These are usually men. What separates this from being just a sexual preference, just along that normal spectrum, is the distress that it causes in self or others. So for example, if a person insists on wearing a clothing item and that causes problems in their relationship, but the person can't change or refuses to change, that probably would border on transvestic disorder. So that distress is really key. These are mainly diagnosed in heterosexual males for the most part, although any person could be diagnosed. And these are not people who wish to change their sex. These are not people with who are any gender can be involved. This has nothing to do with gender orientation or gender identity. And in fact, that has been one of the biggest objections to still having this in the DSM, is because people believe that this may be stigmatizing against many individuals. So some people are afraid that this will be equated with people who are gender diverse, people who wear clothing of a different sex and such, and it is not. It's not the same thing. But the fear is that allowing this disorder to remain in the DSM will stigmatize lots of people. So I'm not really going to say much more about it than that because of this reason. So my guess is that this could be removed from the future DSMs, or it will be very much refined. Okay, the last disorder we'll talk about here is pedophilia. There's just a lot of information to convey, but I'm just going to give you a few highlights. This chapter is meant to be just an overview of disorders, obviously. So the technical definition of pedophilia involves sexual activity with a prepubescent child. Now, obviously, sexual activity with anyone underage is illegal, and you can certainly talk about values and disordered and all of that sort of thing, but technically the definition is with a prepubescent child. So the typical offender is over the age of 16, and there's about a 5-year age difference between themselves and the child. It's usually a male, but not always. And they actually may be indifferent to the child's sex. So for these individuals, it's the youth aspect that's the same. It typically doesn't have much of anything to do with sexual orientation. They are usually the offender is usually male, the victim is usually female, but not always, and there are some age differences. Most females who are victimized are between the ages of 8 and 10. Males are a little bit older, generally 10 to 12 to 13, something along those lines. And most do know their victim. They're usually a family friend. It could be someone else in the child's life. It could be a minister, a coach. It could be an aunt or uncle, teacher, just a wide variety here. We know that some people with pedophilia may become abusive and aggressive toward the child, but most actually do not, because they know that that's not the way to get a child to comply. Generally, what's happening is that the person tries to slowly woo the child. They develop a relationship, a kind relationship with the child in order to gain the child's trust, and then they perpetrate the crime at that point. And some will argue that this is important. They may try and educate the child, deluding themselves and the child that this is important things that they need to learn. In some cases, they may threaten harm to the child's family as a way to keep them secret. And obviously for a child, that's just the worst possible thing, the scariest thing for something to happen to their family. So this can help, they use this to try and help get the child's cooperation. Now, people who have pedophilia, of course, it's hard to get our minds around this, but through studies of them, we know that these folks have some cognitive deficits in place. They don't think like other people. Many believe that the child actually initiated the sexual contact, which of course is false. Many believe that the child will actually benefit from the sexual contact, of course also false. These people are often law-abiding, respected citizens, and may actually have kids of their own, which is shocking to people. They are, though, oftentimes socially immature. They may prefer kids because kids are less demanding than other adults, and they often can't establish satisfactory sexual relationships with adults and may use kids as substitutes. So there's a wide variety of dysfunction that goes on here. The last thing I want to say about this is that this has not been found to be a treatable sexual disorder. There are treatments out there. There are sex offender treatments out there. None of them have been very successful. So, there are situations where the courts will not be as hard on people with pedophilia as they could be. There are attempts to get people into treatment. There are certain kinds of treatments like aversive therapies that may be useful and may be helpful in the short term, but there is nothing in the long term. So this presents one of the biggest challenges to the clinical community, is what to do with these folks, how to keep people safe from them, and how to help them if there is any possibility. It's a difficult issue. Okay, to end this chapter, I want to talk a little bit about just paraphilias in general, just very generally treatment and what causes these disorders. So what we've come up with is this overall model of paraphilia development, how these get started. And here is this fancy model, and I learned how to draw boxes on the PowerPoint, so that's what's listed here. So I'm just going to kind of go through this. There's no single theory that can explain the development of paraphilias. It's probably a combination of environmental factors and genetic factors. So many people with paraphilias have explanations for their behavior. So much of this model has come from interviewing and asking people with these disorders. So I'm just going to run through this and give a few explanations for each of these boxes, and this is how we put this together. So first of all, up at the top, early inappropriate sexual associations. So the role of early experiences which may be accidental or vicarious. So for example, a young boy sees his female neighbor through the window undressing, and just as he's kind of hitting puberty, for example, or an object is present during a young boy's pubertal development that he associates with masturbation, for example. So it's early experiences that may be either viewing something else or accidental. Sometimes porn can trigger these, they found. Then an inability as people get older to achieve arousal appropriately with consenting others. So they find that as they get older, they can't achieve satisfactory sexual relationships with people who consent. This is oftentimes coupled with difficulty with social skills. They may lack the social skills necessary for meeting and dating others and keep relying on the paraphilia for sexual satisfaction. And then early sexual fantasies can actually reinforce and may even predate this behavior. So before a fetishist or a person with pedophilia or an exhibitionist ever acts on his behavior, he may fantasize about it during masturbation, and then that, of course, is positively reinforced. So through operant conditioning, the person is constantly reinforced. And then, because the person probably realizes at some level that something isn't right here, they may attempt to inhibit the desire, inhibit the arousal. There may be some obsessive compulsive disorder qualities about these individuals, but the person is unable to suppress the thoughts that they're having. And that can actually have the paradoxical effect of increasing their frequency. So, we've talked about this with OCD. The harder you try to repress the thoughts that you're having, sometimes the more ingrained they get. Okay, so that's some basic information on some of the sexual disorders. I'm going to assign in the study guide for this exam some reading about treatment. They are usually behavioral treatments. Some are more efficient and workable than others, but I will have you read about that.